Xin chào, dear Professor Hai, ladies and gentlemen. It is my great pleasure and honor to be invited to this important meeting. I give a talk about updates of living donor liver transplantation today. There are so many updates of LDLT, but I picked up interesting and representative 5 topics. LDLT in COVID-19 pandemic, LDLT for colorectal liver metastasis and living donor rapid procedure, minimally invasive donor hepatectomy, minimally invasive LDLT, and safety of HBV positive liver graft. Since December 2019, the threat of coronavirus disease 2019, so-called COVID-19, has changed the current transplant policies and practices. And many transplant centers had to reduce their activity because the theoretical risk of transplantation during the COVID-19 pandemic was higher. You must remember Lombardy, the most effective region in Italy. There has been a drastic decrease in liver donors, but this study has found no specific reason concerning the safety of recipient to stop LT program. However, due to the complex circumstances which surround the viral outbreak, the cessation or reduction in LT activity is a pragmatic requirement. At the high volume center, LDLT activity substantially reduced during the COVID era. They performed LDLT only for sick patients or patients with advanced hepatocellular carcinoma in this period, with a special COVID protocol. The incidence and outcomes of COVID-19 among the waiting or transplanted patients and healthcare workers was similar to those of the general population. The outcome after LDLT in the COVID era was similar to that in non-COVID times. This data suggests that LDLT may be extended to more stable patients with strict protocols. In Korea, the number of LT did not decrease significantly during COVID-19 outbreak. The lockdown caused by COVID-19 did not affect the number of LT. Establishing a safe process and procedure of LT within safe boundaries can be beneficial in reducing the side effects of lockdown and saving patients' lives. In 2021, Korean Association for Study of Liver made a guideline for the liver disease management during the COVID-19 pandemic. I picked up 3 topics related to LT among them. In the management of patients with decompensated cirrhosis or waiting for LT, high mortality rate were reported for COVID-19 patients with cirrhotic liver disease, around 40%. And in a multi-center study of hospitalized cirrhotic patients who tested positive for COVID-19 reported an increased mortality rate compared to COVID-19 patients without cirrhosis matched for age and sex. However, the difference in the mortality rate was not significant compared to cirrhotic patients without COVID-19. And there were no significant differences in respiratory symptoms and clinical outcomes between COVID-19 patients who had underlying liver disease and those who did not. Based on the research to date, although there is a greater risk for COVID-19 infection in healthy patient. This is not independently associated with an increase in mortality. So, irrespective of the COVID-19 pandemic, LT should be conducted according to medical guidelines to minimize the risk of COVID-19 infection. Minimizing the dose of immunosuppressant, especially antimetabolites, should be considered in LT patients confirmed with COVID-19 infection. Regarding the vaccination strategies, it is clear that COVID-19 vaccination should be prioritized for chronic liver disease and LT. Although COVID-19 vaccines pose the risk of thrombotic events, the greater benefits of vaccination have led to the recommendations for active vaccination. All chronic liver disease and LT patients, including vaccinated recipients, should continue to adhere to infection prevention and control guidelines and also practice social distancing. The role of LT in the treatment of colorectal liver metastasis is still under evaluation with a series of clinical trials ongoing. Recently, national and international guidelines are taking into account these therapeutic options. The IELTS Transplant Oncology Consensus Conference and the Spanish Society of Liver Transplantation published their recommendations for LT for colorectal liver metastasis. With moderate evidence and recommendation, LT can be a viable option in highly selected patients with unresectable colorectal liver metastasis with only liver involvement. And liver transplantation for colorectal liver metastasis with a low Oslo score less than 2 may improve the 5-year overall survival rates over those achieved with the current standard of care. Spanish Society of LT recommends that in selected patients with unresectable liver metastasis of colorectal cancer, LT could be considered only in the context of well-designed clinical trials and after a close evaluation by a multidisciplinary team composed by oncologists, hepatologists, and surgeons. Here's an interesting technique in the management of unresectable colorectal liver metastasis. Living donor rapid procedure composed of a living donor resection and partial liver segment 2-3 transplantation with a delayed total hepatectomy is designed to use left lateral graft for donor safety and to apply APOL to avoid the small foci syndrome. The principle of this technique is to resect left liver and transplant the patient with a small auxiliary left liver graft and ligation of right portal vein, followed by residual hepatectomy at a second stage when the transplanted graft has regenerated to a sufficient size. Liver transplantation for colorectal liver metastasis is a valid option in highly selected patients. The rapid procedure is a feasible option to expand the donor pool for liver transplantation for colorectal liver metastasis. Living donor rapid balances low donor risk and access to transplantation for selected patient with colorectal liver metastasis. The rapid concept is still experimental surgery and should be implanted in the context of prospective clinical trials. Laparoscopic liver donor hepatectomy become more and more popular in the world. Samsung Medical Center achieved complete transition from open to laparoscopic donor hepatectomy in 2020 with the 8 years of experience with more than 500 laparoscopic cases. There were no differences in the occurrence of grade 3 complications of donor and recipient throughout the study period. Mean operation time became similar since 2017. There was no difference between open and laparoscopic group in graft survivor and overall survival of the recipient. In the initial period, donor selection existed, especially for bile duct variations to maintain the safety of the donor and recipient. However, complete transition to laparoscopic donor hepatectomy became possible with accumulated experience. In the study of Seoul National University Hospital to determine the safety and feasibility of pure laparoscopic living donor right hepatectomy, they concluded that pure laparoscopic living donor right hepatectomy is currently feasible and safe even for donors with anatomical variations owing to the technical improvement over time. There was no requirement for intraoperative transfusion or care in the intensive care unit. Complications were not different among 3 periods, even though the instance of anatomical variations such as multiple portal vein, multiple hepatic arteries, and multiple bile ducts were much higher, over 50% in the 3rd period. Expert consensus guidelines on minimally invasive donor hepatectomy for LDLT was published in Annals of Surgery 2021. It concluded that pure laparoscopic techniques are the most commonly used compared to laparoscopic assisted and robotic assisted ones. They believe that the present guidelines will provide the foundation for the safe diffusion of this unavoidable technical advance in the field of liver transplantation, with the donor safety as the priority. Recently, a couple of reports of minimally invasive living donor liver transplantation were made by SNUH Korea. 5 cases of a pure laparoscopic explant hepatectomy and graft implantation using upper midline incision were reported. The procedure was completed in 3 of the 5 patients. Total operation time was 499 to 640 minutes. All patients recovered well. Furthermore, a pure laparoscopic explant hepatectomy and pure laparoscopic implantation of the graft was performed successfully. The graft was inserted through a suprapubic incision, and implantation was performed intracorporeally through the procedure. The time required to remove the liver was 369 minutes, and the total operation time was 960 minutes. It was so long, but the patient recovered well, and his hospital stay was 11 days. Dreams come true when performed by a highly experienced surgeon and transplantation team. Maybe it gets shorter and shorter. Last but not least, I'd like to talk about the liver grafts from hepatitis B surface antigen positive donors. And then the main reason it might be a source of extended donor graft. The first report of HBs antigen positive donor liver graft due to an urgent need was made in 1994 prior to antiviral agent. Fortunately, loss of the serum HBs antigen in stable condition was observed 2 years after liver transplantation. The previous guidelines have suggested consideration of organs from HBs antigen positive in urgent non-renal transplant candidate with HB antiviral prophylaxis and informed consent. Consideration should be made in endemic regions where potential donors are frequently HBs antigen positive. A nationwide study of safe use of hepatitis B surface antigen positive graft in LT was performed based on Korean organ transplantation registry data. 39 cases, 0.9% of total 4,265 LTs used HBs antigen positive grafts. They remained on HB or antiviral agent or both in the perioperative period. There was no difference in the patient survivor between HBs antigen positive and HBs antigen negative graft transplantation. They also confirmed that HBs antigen positive liver graft can be used safely with expanding donor pool in HBV endemic area. I think it can be safely applied to Vietnam. Thank you for your attention. Stop.